In this episode of The Bear Roars, Dan Caruso sits down with Dr. Bill Blanchet, a Boulder-based physician whose curiosity led him on an unlikely journey from Colorado to Cuba. Dr. Blanchet shares how a chance encounter with a patient battling stage 4 cancer opened his eyes to Cuba's cutting-edge biopharmaceutical breakthroughs, from cancer immunotherapies to a potential game-changer in the fight against dementia. He reveals how Cuba, long underestimated, became a hub of medical innovation, and why its latest discoveries could reshape the future of global healthcare. Facing embargo barriers and entrenched skepticism, Dr. Blanchet forged partnerships in Cuba that challenge how we think about innovation, medicine, and global cooperation. Let's poke the bear to kick off the conversation.
Well, Dr. Bill Blanchet.
That's me.
That is you, and you are my personal doctor. In fact, you are my personal doctor who, the first time I saw you, you said, yeah, I think something's wrong here. And you did some tests, and next thing you know, I'm
doing stuff
to try to get rid of some cancer that found its way into my body. And so I owe you a lot for having taken care of me all these years.
It's a pleasure just doing my job.
Yes.
Just doing my job.
Well, you're doing more than your job, but that's not what this podcast is about. This podcast is about Cuba. And about some things that are coming out of Cuba that you're involved with that could be really exciting. So what I'd like to do is start with telling us about, when I think of Cuba, when you first shared this with me quite some time ago, I, like probably most people listening to this, are like, what does Cuba know about modern medicine? Aren't they a backwards country? Why would we ever be looking toward Cuba as a source of advanced medicines, advanced treatments? So tell us about Cuba's history.
Yeah. Well, Cuba's history is kind of interesting. Back about 30 years ago, about the time the Soviet Union or Russia was pulling out of Cuba, Cuba's economy was in desperate shape. Castro recognized he had this genius immunologist, Dr. Laje, and other very smart immunologist doctors who were coming up with designs on drugs, designs on treatments. And he thought, these are really good. I want to support you because I think if I support you, you will be profitable, you'll be good for Cuba, just be good. And so he put a huge amount of money into these clinical research and production.
Well, tell us more about this doctor.
Dr. Laje he's immunologist.
How do you spell?
L-A-G-E.
L-A-G-E.
Yeah. I mean, his name is much longer. It's many other names on top of it.
Okay.
But Laje is easy to remember. And so he's basically an immunologist who was coming up with cancer therapies. And so Castro wanted to commercialize.
And this is what time frame? This is
about 30 years ago.
About 30 years ago. Yeah. So let's see, that would be about
in the
1990,
yeah,
thereabouts.
Right. And it's kind of interesting. I had a chance to talk with an economist in Cuba a couple of months ago, and he was around when Castro first made this investment, and everybody thought Castro was out of his mind to do this. We have limited resources. What are we doing investing in biomedical, pharmaceutical research? That's crazy, except it wasn't, because that's now Cuba's most successful export item is the biopharmaceuticals. Now they export them to China, Russia, Venezuela, Iran. They don't export them to many other countries. There's something called an embargo that limits what they can do there.
It's for entirely political reasons. You said embargo, but it's the reason they don't have U.S., Canada, Europe as markets is because it's prohibited.
It's prohibited.
It has been prohibited.
Yeah.
So they have this doctor who's a genius.
And they've developed quite a number of biopharmaceutical products. And because it's profitable, even though Cuba is a very poor country, the biopharmaceutical industry is self-supporting, self-generating. And so it keeps going, keeps developing. And like I said, they've come up with some truly remarkable things, which I knew nothing about. I knew nothing about this. So this economist who said, back 30 years ago, thought Castro was out of his mind to do this, realizes this is brilliant. This is our best export product right now. So Castro was right. Which takes something for economists to say they were wrong. Most economists can't say they were wrong.
They usually say the economy's wrong, not them.
Yeah, exactly. And so So I was completely ignorant of this. But in 2017, I had a patient who had stage 4 lung cancer. And he had multiple metastases in his chest, multiple metastases in his abdomen. And he had a metastasis in his brain that gotten radiated. And he comes in to see me one day and says, I want to go to Cuba to get immunotherapy for my lung cancer. which I thought was, at one side of the coin, kind of insane. But tell you what, if I had metastatic lung cancer, I'd probably want to go to Jamaica or Cuba or somewhere just to get the hell out of Dodge. But his son-in-law saw this program on Cuban immunotherapy on Sling TV. So based on that, he wanted to go to Cuba. And so I said, well, listen, if you want immune therapy for your lung cancer, go while you still have an immune system. Go now. And if you go now, I'll go with you. Because if this is real, which I didn't think it was, I need to know about it. If this is foolish, you need to know about it. And so we went together. So in October 2017, George and I fly down to Havana, meet with folks at La Pradera International Clinic, get started on this monoclonal antibody. The oncologist there knew everything there was to know about cancer. He's really, really smart. He said, based on the type of cancer you have and the treatment you're currently getting, which was an epithelial growth factor mutation treatment that kept the cancer growing slowly. It didn't kill it, just kept it growing
Yeah,
slowly.
we're going to have you explain some of these deeper medical terms.
So epithelial growth factor is something that stimulates growth of epithelium, like your skin.
Okay.
Many cancers need epithelial growth factor to grow. Some cancers have a mutation that genetically they make a different kind of epithelial growth factor, and those patients you can take a pill, something like Tigresso, and it stops the cancer from growing for a while. And George had been on this pill for a couple of years, and his cancer had not grown for a couple of years, and then was starting to grow. As the oncologist was saying, we'll be needing chemotherapy soon, and George really didn't want chemotherapy. So at that point in time, we got down to Cuba. And the oncologist said, since you're already taking something for the epithelial growth factor, the drugs we have for epithelial growth factor we're not going to use. But we have this other drug that goes after an antigen, a little protein hidden inside the cancer cells. It finds that protein, unmasks it, and then your body attacks it and kills the cells. So let's use this antibody, monoclonal antibody. And so it's a laser-focused monoclonal antibody. It doesn't hit
And what were
anything
you
else.
thinking when they were describing this?
Well, first off, I was kind of surprised by how much she knew about oncology. And when she was explaining this, she had this breakdown of all of the antigens found in a cancer cell and said, this is the antigen we're targeting, and no other human cell has this antigen, so you're not going to get ill from this because it's not attacking human cells, it's just attacking your cancer. And I'm thinking, well, yeah, I'm still skeptical.
Yeah.
I mean, we're talking about, this is Cuba. I'm still skeptical. Well, this is October 2017 he gets started. The doctor also said initially the cancer is going to get bigger because as your body attacks it, it swells and gets bigger, and the antigens will go up because as the cells die, it releases the antigens in circulation. So initially it's going to look like the cancer is getting worse. Starting in October, by January, it looked like the cancer was getting worse. His nodules were bigger, his antigens were elevated, and I pretty much wrote it off as, this ain't doing anything. This is not going to work. However, July of 2018, he repeated his PET scan and went from having multiple metastases to having no metastases, zero. And his antigens, his blood...
And explain how rare that is, like how...
That doesn't happen.
It doesn't happen.
That doesn't happen. With most therapies, we hope to see the tumor either grow more slowly or shrink a little bit. But his was gone. His antigens were gone. His blood tests were normal. He went from stage 4B cancer, which means he already had some systemic symptoms from his cancer.
And that was pretty much a death sentence at that point.
Absolutely. To having zero cancer in that 9-month time frame. And so at that point in time, it's like, okay, maybe Cuba has something. Maybe Cuba has something. And so this is a unique drug developed by Cuba, available in Cuba.
What happened to that individual? Are you going to...
So, yeah, he continued to take the medicine, continued to do well. He had a little bit of recurrence here that came and went, a little recurrence here that came and went, but he did well. Unfortunately, a year and a half into it, and he continued to work full-time. He ran the Boulder twice, things like that. Unfortunately, a year and a half into his treatment, the State Department increased the embargo to Cuba. The drug became unavailable. And without the drug, his cancer came back. And he did go through 3 rounds of chemotherapy, and each round made him sick, and none of them made him better. And he was really weak and really at the end of his rope. When I was able to talk with the oncologist in Cuba and was able to get some medicine, the same medicine, brought it back to him. And in 6 weeks, his CEA, one of the cancer antigens, dropped by half. So he was responding. But he was so beat from the 3 rounds of chemotherapy and as sick as he was, he just tapped out. He said, I can't take this anymore. And he went to hospice, got a single dose of morphine, and went to sleep, never woke up. So if we could have maintained the drug, things would have possibly well, certainly would have lasted longer. I don't know what the end of the story would be. He might still be around today. Interestingly, there's a Nova documentary called Cuba's Cancer Hope that features George as one of the main people in this documentary. I have a bit part as George's fat friend sitting at the pool, but it was truly remarkable. At that point in time, it's like, okay, these folks in Cuba know some stuff that I don't know. And so that got me interested. I had a couple of other patients. They have another monoclonal antibody that treats glioblastoma multiforme. And I have a couple of patients who had glioblastoma, but they decided to get treatment late in the disease. And we get to treatment late in the disease after you've been through chemotherapy and your immune system's gone. And then you ask the immune system to get rid of disease, it's not easy to do. In both cases, seemed to stabilize the glio, but didn't make the patients better. And they started the treatment at such a diminished level of function that since they didn't get better, we decided to discontinue the treatment. So I've not had another win like I had with George, but it informed me as what was going on in Cuba. Then COVID comes along. And with COVID, it's like, okay, we're not going to Cuba for a while. Here's COVID. And I hear that Cuba is developing their own vaccine for COVID. And I'm thinking, we'll see how that happens. I'm still so egocentric. Even after seeing what happened with George, I'm not buying that Cuba can do anything remarkable. Well, Cuba takes the COVID antigen and treats it in an old-fashioned conjugated antigen vaccine, like they do for hepatitis B and Haemophilus influenza, and create COVID vaccines and test it, and find one vaccine was 93% effective in stopping COVID, the other was 97% effective in preventing clinical COVID. And neither one of them had any meaningful side effects. It's like, wow, is this true? Is this real? Or are they just making this up? Well, today, Cuba has not had a COVID death in 2.5 years. The United States had about 50,000 last year. I know of 2 people who've died from COVID in the last 12 months. And so Cuba's not had a COVID death in the last 2.5 years. And on top of that...
During COVID itself?
Yeah, during COVID, if you remember, the initial COVID happened, and then it started coming down, and then we hit Delta COVID, got a big spike, and started coming down, and then we hit the next one, and that one's never, ever come down. Well, in Cuba, first COVID, Delta, and they vaccinated during Delta. COVID came down like this, and with the final COVID, it never took off. A little bump, and then leveled off and gone. And so they have been without COVID for 2.5 years. They were working on developing a new vaccine against the current strain of COVID and realized COVID is no longer a public health issue for us. There's no reason to develop a new vaccine, and decided not to develop it. When I talk to my friends in Cuba, I love just asking people, group people, when was the last time you knew someone who had COVID? I get the same answer every time. First, I get this confused look, like, why are you still asking about COVID? What's that about? And they say, haven't seen anybody in 2 years who's had COVID. Ask someone here, was the last time you met someone who had COVID? Well, it was this morning.
Half our office had it a couple weeks ago.
That's right. Half an hour ago, yes. Half an hour ago. And so
I remember you told me a story once where you got in a cab and asked the question to the cab driver, how's COVID? So maybe retell that story. That was one that I remember.
Well, the 2 things that went there is, first off, he's like, well, we've been vaccinated. There's no COVID. It doesn't exist. And then I said, well, what? There's so little traffic here. What's going on? He said, well, during COVID, we all got used to just staying home in the evenings. It caught on. Now everybody's staying home in the evenings. No one's going out anymore. And so I have known of a couple of cases of tours that have come from the United States or from Italy and brought COVID with them and shared COVID among the Americans or the Italians, but the tour guide and the bus drivers never get sick. In fact, in the Italian group, one of the Italians died from COVID in Cuba, and the tour guides and bus drivers never got sick. In a group of 5 Americans in an enclosed bus, 9 Americans in an enclosed bus, 5 of them got COVID during the tour. The tour guide and the bus driver never got a symptom. So do I think that their vaccine works? Yes, I do. They have 2 vaccines. They tested one of them in adults with over 1 million adults. They tested another one in children with over 1 million children. And in both test groups, no one was hospitalized as a result of a vaccine complication. No one missed a day's work as a result of a vaccine complication. And when the children went back to school after getting vaccinated, there was no change in the incidence of COVID in the country. Now, you can say, well, you don't believe it, I don't believe it. If you met the people who do this stuff, who do this work, you'd realize this is very believable. These are not people who are kowtowing on a public project. These are scientists. These are researchers. They're incredibly, incredibly believable. So I think that sitting down in Cuba is a vaccine that if we had in this country, COVID would no longer be a thing. I truly believe that. But getting stuff from Cuba to the United States is difficult. So we're going along. Getting back to George, my patient with lung cancer, on his last PET scan before we went down to Cuba, he had a hot spot in his prostate. And the lung cancer generally doesn't go to the prostate, and the radiologist said he probably also has prostate cancer. So we checked the PSA. His PSA was elevated. And we said, we're not going to pursue this because you have stage 4 lung cancer. If in 10 years from now we're still working on this, we'll worry about your prostate. We're not worrying about it today. Well, 9 months later, when his PET scan was normal in his lungs and his abdomen, the spot in his prostate also disappeared. So I rechecked his PSA, and his PSA was now normal. It's like, did he have prostate cancer, and did his prostate cancer go away with his treatment? That's what this looks like. So I was talking to a friend of mine who I found out later is the head of immunologic oncology in Cuba. I just met her through a mutual friend. And I presented George to her and said, well, prostate cancer contains the same antigen that lung cancer does. It's reasonable that he could have the same reaction and the prostate cancer could be eliminated with the same drug. And so at this point in time, I have a couple of patients in my practice who are in that position where we don't have anything we're offering. We're just kind of waiting for things to get worse, or they're past the point that there's anything left to offer. And so I go down to Cuba and say, I go down to my friends in the CIM, Cuban Immunologic Molecular Research Facility, say, would you consider doing a study on prostate cancer using Americans? Because if you do a study on prostate cancer using Cubans and you get great results, it'll be like every other study you've ever done. No one will hear about it. No one will care. If you do a program with Americans and you get great results, people will hear about it. People will care. I said, yeah, we could do that. Boom. I didn't expect that fast a response. I said, yeah, we could do that. I proposed this to them in November. By May.
November what year?
November of last year, 2024. By May of 2025, the project was up and enrolling patients. And so we don't know the answer to the question yet. The patients who are enrolled in this project have not been enrolled in it long enough to know if it's going to work or not. But there are no side effects. They're tolerating it very well, and they're delighted to have something that might change the course of this disease. And so I was working on the prostate cancer angle, and I knew that they had a study on Parkinson's and dementia in the works. And so before one of my trips to talk about this prostate cancer research, I Googled Cuba dementia, and the Athenia trial popped up. I was like, wow, this is great. I read it. It was pretty technical, pretty
Actually,
complex.
before we go there,
Sure.
let's just to close the prostate test. How many are going through that test? How many?
Right now, we're walking slowly. We only have 2 people enrolled at this point in time.
Okay.
I have a few more who are given it strong consideration. And the thing is, I'm just making people aware of it. I'm not pushing it. I'm not saying this is something you got to do. It's just that here is an option. But we're not going to pull out this option if there is a standard of therapy that can cure your cancer here. We don't, that's not what this study is about. This is a study if you're in a position where you're waiting for something worse to happen. This is a good time to get on this study. And let's see if it works. If it works, this could revolutionize how we treat prostate cancer. If it doesn't work, no harm, no foul, because it's a medication that's been around for quite a while, for over 10 years, and the side effects are almost nothing. Some people get a degree of fever, some get a little bit of soreness where they get the shot, but no real adverse effects in the patients who've gotten it. And so it's like, right now we're waiting. The longest term patient's been on for 4.5 months. And I'm suspecting it's going to take 9 months to start to see the remarkable clinical results like we did with George, because at 3 months with George, his cancer looked worse. It was at 9 months his cancer was gone. And so I'm thinking 9 months is our threshold before I make any negative observations about the study. At this point in time, we're just watching, make sure there's no unexpected side effects.
Gotcha.
And so we should know, in December, we're going to have our
And
first
do they
6-month follow-up.
Do Cubans treat Cubans for prostate cancer with this?
No. And so it's never been studied in prostate cancer. And the problem is you're looking at a country that's very poor, an impoverished country. Prostate cancer tends to occur in older men, and with testosterone depletion, you get another 7 to 10 years. They don't see a pressing need for other therapies, particularly expensive therapies. In this country, it's a different story. We want other ways to treat prostate cancer. That would be a good thing. And so it's not yet used in Cuba. I suspect if we find this works, they're going to rethink that. And this particular antibody, Vaxira or racatumumab, is having kind of a renaissance in Cuba. They're seeing new ways to use it. They're producing a larger volume of it. It's even though it's not a new drug, it's becoming a more popular drug, a more popular treatment again. And so we'll see what happens. At this point in time, it's interesting, it's promising, but it's not certain yet.
Yeah.
Interesting, promising, not certain.
So now we're going to get to the real interesting part of all this.
This huge, interesting
Yes.
part, yes. So as I was saying, I've been interested in their drug for Parkinson's and dementia. And I have friends with Parkinson's, and I have a brother with Parkinson's. It's like, if this drug can work and stop Parkinson's from progressing, that would be huge. And I'm thinking more Parkinson's than dementia. And a couple of years ago, I called down to the Neurologic Institute and said, I hear you have a drug for Parkinson's and dementia. What can you tell me about it? And they said, it's in a phase 3 trial right now. I can't tell you anything about it. Call back in 2 years. And so called back. It's been about 2 years as published. And so I contact my friends in Cuba and say, is it possible for me to meet with the people who designed this drug and did this study when I go back to Cuba to talk about the prostate cancer study? They said, probably. We'll see what we can do. So I go back to Cuba to talk about the prostate cancer study, and I go into the Immunologic and Molecular Institute to their conference room, and 14 people walk in. Half of them to finish setting up the prostate cancer study, and the other half to present the dementia drug, this neural sim.
Okay, so let's start here in Boulder, Colorado. How do you get from here to Cuba?
Yeah.
And then take us through the story where you get to Cuba. Where'd you stay?
Yeah.
And then
Sure.
as you walk into that room, what were you expecting?
Yeah. Well, to get from Boulder to Cuba is not difficult if you're going there for research purposes. And I was absolutely going there for research purposes, no question about it. And so I just get a research visa and fly from here to Miami to Havana. No problem, no
pretty
sweat.
easy.
Easy breezy. In my first trip to Havana, I was a little afraid of what immigration would feel like, or passport control would feel like in Havana. I was expecting these old lieutenants with cigars and glasses giving you the sneer.
Yeah.
Actually, there's kids there. They're like 20-year-olds who are happy to see you. And you go in, it's not at all daunting.
How are they seeing Americans show up there?
To my surprise, they really like Americans in Cuba. Why Cuba would like Americans, considering what the embargo has been doing for them for the last 60 years, I don't know, but they like Americans. I give you an example. I had a tour guide who had a group of Americans, and she needed to find a hotel for these Americans. And she called the hotel and said, do you have any rooms? He said, we're just about full. What have you got? Said, I have a group. Said, where are they from? Said, the United States. We have room. I think we tip. That might just be it. Maybe because we tip. But so Americans are seen as a good thing in Cuba. And when I talk to people in Cuba who are a little bit higher up in the, I wouldn't say in the administration, but in the upper levels of the research and production facilities, they really would love to have a good relationship with the United States. They think there's a symbiosis here that could really send things to a different level. And so we'll see what happens. It's just one of those odd things. Getting to Cuba, the first time I stayed at a hotel called Havana Panorama, which is like a 4-star hotel that you have here, a beautiful swimming pool, nice view of the Gulf, the whole thing. And the second time I stayed at Milan Cohiba, hotel. Once again, a 3-star hotel. Next couple of times I stayed at another one that's a 4-star hotel. It's beautiful. But what's happened is the State Department has made those hotels off limits for Americans. So I can no longer stay at any of those hotels. So now when I go to Cuba...
Why did they change that?
Well, there's this concept that Cuba is a country that supports state-supported terrorism. Now, that's because 30 years ago it was. 40 years ago it was. They had troops in Africa, they had troops in Central America, and so you could make that argument. It's no longer a valid argument, but it's their position, State Department's position, and has been for a long time. And so if a hotel has any ownership by Cuba, and you're paying for your hotel room, then you say, well, you are supporting terrorism by paying for your hotel room in Cuba. So that's what the State Department's limitations. So there are some small hotels that are individually owned, the Cuban government has nothing to do with them, that are fantastic. And so we the last time we were there, we stayed at a place called Casa Italia, and it was just a gorgeous little hotel. And so we didn't lose any quality, but it has limited rooms. So it may be full, so I can't always get there. So we have a secondary Airbnb that's not quite as good, but has a bed and has an air conditioning when it has electricity, which is not, every day in Havana, they're without electricity for 3 hours every day. In the provinces, they're with electricity 3 hours every day.
Wow.
It's pretty brutal right now. It's pretty, by American standards. So we stay in the hotel. It's a lovely hotel. Taxi drivers love us. Every time I get a taxi ride, they give me their car and say, if you need anything. And you'll get a taxi driver who will take you somewhere and just say, I'll wait. And they'll wait 3 hours for you. You come back, they're sitting there, you hop in, they take you wherever you need to go. It's like having your own private driver for like $35 per trip. It's easy. It's easy. And the people there, if you know where to eat, has fantastic food. If you know where to go, has fantastic music, has great places to dance if that's your thing. And so as I've been there, I've learned where to go to get some good food. But that's not why I'm there. I'm there because of the biomedical research that's there and find out what they have, what they can offer. And so many times I've stayed at La Pradera, which is the international medical facility. And so if I go down with a patient and the patient stays at La Pradera, I'll stay at La Pradera with the patient. And it's a beautiful, like 60-acre tropical paradise with a pool. And it's not bad. It's not bad, but it's not quite a 4-star hotel. And with our American expectations, we want the 4-star hotel whenever possible. So that's getting into Cuba. It's not nearly as hard as you think it should be. And once you get there, it's much more easy to have a pleasant stay than you might think it is. As it turns out, Havana is one of the safest big cities in the world. I looked at Chicago and New Orleans have like 10 to 14 times the crime rate of Havana. It's like, so, I was one time taken to the back residential area of Havana by a couple of people that I knew. They just wanted me to meet their mother and see where they lived, educate me as an American as to what life was like in Cuba. And I did, and once again, I never felt threatened or uncomfortable. But then I come home and tell my kids that, we went back to the afueras de Havana, the suburbs. They're like, do you check and make sure you still have 2 kidneys? Do you have any scars back there we need to worry about? But it was very pleasant. And so I feel very comfortable going to Cuba. At this point in time, I've gotten to know many of these people in the research facilities. I've gotten to know many people in the international healthcare facilities. And so I'm getting ready to go down to talk about this prostate cancer thing. And I see that this drug for dementia and Parkinson's has been published on. So I'm going to go down and hopefully meet with someone with this group. Like I say, we go into the conference room at CIM, the Cuban Immunological Molecular Research Facility, and these 14 people come in. We talked about the prostate cancer for about 15, 20 minutes, got everything taken care of. And then they give me a presentation on this drug. And at the end of the presentation, I had to pick my jaw up off the floor and reattach it. It was just like, wow, can this be real? Of course it's real. Why do I say this? Of course it's real, because I know these people who did the study. And I know what their motivations are. So what they found was they had a phase 2/3 trial. A phase 2 trial, you're trying to find which is the best dose of the medicine. And a phase 3 trial, you're comparing it against a placebo, see how well does this work against nothing.
Is it double blind there in
Double
Cuba?
blind, so the patient doesn't know if they're getting the drug, the doctor who's administered doesn't know, and the people who are overseeing it don't know until they break the code. And so they had this phase 2-3 trial going, and they had 2 different doses of the medicine, and both doses had the same results. So they just put that in as treatment. So 170 patients, 2/3 were treated, 1/3 got salt water. It's a nose drop 3 times per week. It's a half a cc nose drop 3 times per week, quarter cc in each nostril. Well, the placebo group, at the end of 1 year, 85% had progression of their dementia. At the end of the 3rd year, 98% had progression of the dementia.
So the third who didn't get the drug,
All of them got worse.
all of them got materially worse.
Material worse, demonstrably worse. Of those who did get the drug, and this is where my jaw first dropped, 54% at 1 year were improved.
Improved.
Improved. They did better on cognitive assessments, were improved. And 30% were stable. So 84% were either improved or stable at 1 year. And of those improved or stable at 1 year, all of them were still improved or stable at 3 years.
Wow.
Yeah. And then talking to the researchers.
And how many people were in the study?
170.
So 170, so a pretty, what you'd
reasonable
say is a
size,
really
yeah.
good sample size.
Well, in science, we look at a p-value, and the p-value has to be less than 0.05 to say it's statistically significant. And that means there's a 95% chance this is cause and effect, not just random chance. The p-value on this study, even though it's a relatively small study, was not less than 0.05, it was less than 0.00005. So there's virtually no
because
chance.
the difference in the two groups
Difference
was
is so stark, so stark. I mean, 84% versus 98%, so stark. You had 3 people in that study who have been statistically significant.
And this is all dementia or Parkinson's?
This is all dementia.
Okay.
So they have a second phase 3 trial ongoing right now with 616
And
people.
when you
in
say
it.
dementia and Alzheimer's, can you differentiate
Certainly,
between
yeah.
those two? And does Alzheimer's become part of this conversation as well?
Absolutely. So dementia is when your brain doesn't function as well as it should. Your memory's not good, you get confused, processing becomes more difficult. Alzheimer's is the most common cause of dementia. There are other causes like vascular dementia, a closed head injury can result in dementia, strokes can result in dementia, but about estimated 65 to 75% of dementia comes from Alzheimer's. In this Cuban study, they did not prove these people had Alzheimer's. They just proved they had dementia.
Okay.
And they've been criticized for just looking at dementia instead of Alzheimer's. And from my perspective, I think that's great. If this can treat things other than Alzheimer's, and if 84% were improved with this drug, were improved or stable, by definition, they were treating things other than Alzheimer's. That's fantastic. I don't need to know. I care if my patient has dementia, and I love it if I have a drug that works for that. I don't get any extra points if it's vascular versus Alzheimer's. Once they're dysfunctional, they're dysfunctional.
And when did you learn about the outcome of this study? That was very recently,
That
right?
was March of this year.
Okay, so that's just from the time we're recording this, 6 months ago.
Yes, right.
So 6 months ago, you're learning
I'm learning
about
for
the
the
3-year
first time.
study.
Yeah. In fact, I was planning on staying in Cuba for a week doing some other things while I was there. I got this report. I had to come home, get the ball rolling. This is too important. This is incredible. And so
So get the ball rolling. What you decided is you need to do something about this.
we need to do something. Let's look at dementia in the United States. There are about 7.2 million Americans with diagnosed dementia right now. And so if you look at those with diagnosed Alzheimer's, if you look at those with dementia and not Alzheimer's, that's another 20%. So we have like over 9 million, 9.6 million people in this country who are becoming more and more disabled from dementia. Let's assume this drug is only 70% effective in stabilizing instead of the 84% that they showed in their study. Only 70% effective. If this drug were available in the United States today, we could prevent over 700,000 Americans from becoming non-functional from dementia every year. Over 16,000 per week we could prevent from becoming non-functional from dementia. If we were able to do that, not only would we save the heartbreak of taking care of a family member and watching your pops or your mother just go downhill, we would save healthcare dollars exceeding $300 billion per year when you look at the cost of treating advanced dementia. We'd save $40 billion per year in nursing homes alone. And so the case here for getting this drug in the United States is so overwhelmingly compelling that this has to happen. We have to be able to find a way to make this happen. So I've kind of made that a priority. Let's figure out what we have to do to get this drug into this country. And so that's the story on dementia. They're currently doing a second phase 3 trial with 616 patients, so a bigger trial. And they have 289 patients who have done a full year on this trial. And so the Minister of Health asked for a readout on the first year on these 289 patients, and they got roughly the same results as they did on the original trial. Now, the original trial was a single-center trial, and you always get better results in single-center trials. They follow the protocols more exactly. The multi-center trial, you get a little bit worse results always. They got a little bit worse results, but roughly the same results. And so based on that, the Minister of Health said, we're going to give this drug accelerated approval, contingent upon you continuing to monitor what's going on. And so they did. So this drug has been available in Cuba since March. There are over 1,000 people in Cuba taking this drug right now. Well, what would motivate the Minister of Health to get this drug approved early? If this drug is approved, it's going to cost the Cuban government money to manufacture and distribute it, and no one's going to make a profit. No one's going to make a dime. So there's not a financial motivation to get it approved. The only reason to get it approved is that the value to the patients is that sufficient. And the value
Because
to
in Cuba, the economic burden of someone having dementia is
substantial.
Yeah.
It is. It's not as substantial as here, but if your daughter can't go to work because you have to stay home and take care of mom,
Yep.
that's a big deal. And so they approved it because it was that valuable, not because they were going to make a lot of money. You know, in this country, we have 3 drugs that have been approved for treating dementia. One of them was subsequently withdrawn when they realized it actually didn't do anything but have side effects. There are 2 that remain on the market, and what they do is they reduce the rate of progression of dementia by a little bit, like 12%, something in that ballpark. And not to say that has no value, but that's what got these drugs approved, is a small reduction in how fast dementia gets worse. This drug in Cuba, 84% were stable or improved. Mind-boggling.
So why does Dr. Bill Blanchet from Boulder, why do you discover this and our State Department doesn't discover it? Kind of our big pharma companies don't discover it. Our venture capitalists who focus on biotech don't discover it.
Well, there's a couple of things here. First off, there are some big pharma that has discovered it. In fact, one of the largest pharmaceuticals in the world had their president and a contingent go to Cuba to look at their biopharmaceuticals and reviewed it and said, this is fantastic. We want to take your drugs and bring them to the rest of the world. Then they fly back to Geneva, meet with legal counsel, and legal counsel says, don't touch it. If we start marketing Cuban drugs, the U.S. State Department may embargo our drugs. If that happens, we're out of business. So they called Cuba back and said, I'm sorry, we can't do anything. Done. I am trying to put together a group to facilitate getting this drug in this country. I was trying to contract with one of the largest, most respected support consultants for doing this. And I talked to the first person, and she said, I'm getting goosebumps, getting so excited about this product. She brings somebody else in and says, oh, this is fantastic, give me the information. We'll give you, put together your performance, put together your business plan, stuff like that, for $1 gazillion. And then they took it to legal, and legal said, no, sign off. Legal would not let them even consult with me on this because of Cuba. Cuba and the State Department is a scary, scary thing. So I guess maybe I don't scare as easily as some people. What it is, I do scare easily. Just, I can't sit around and let 16,000 people every week become non-functional from dementia when there's something 90 miles south of Miami that can make a difference here. Or 9 miles south of Key West, not Miami, Key West. They can make a difference. And so it's like this is a life-saving, game-changing pharmaceutical. And I'm certain that the State Department looking at the value of this drug to the people of the United States isn't going to step on it.
So what are you doing now to try to get momentum around this?
Well, first off, I'm getting the license from Cuba to allow me to manufacture and distribute the drug in the United States and outside of Cuba. So outside of Cuba's current dome of existence, they're giving me the license to distribute this drug. OFAC, the Office of Foreign Asset Control, has a general license that allows you to import drugs from Cuba, do research on the drugs in Cuba, manufacture them, and sell them in the United States. You need a specific license to sell outside of the United States. So as of today, under the general license with OFAC, we have State Department permission to bring this drug in, test it, do an FDA trial.
How'd you figure that out?
I have some really smart attorneys who are not afraid of the State Department. And so we're in a position, as soon as we get a couple of things lined up, one is going to be to line up solid manufacturing in the United States. And I have a couple of leads there. Getting the technology transferred from Cuba.
What will manufacturing look like for this?
So the technique for manufacturing we use for many other biopharmaceuticals. It's actually using Chinese hamster ovarian cell cultures. They're these cultures of cells that were originally derived from Chinese hamsters, which is a type of hamster. You don't have to go to China to get it. Mm-hmm. And that's how they make erythropoietin. I think that's how they make insulin for some people. There are various biopharmaceuticals. They're made with reverse DNA technology, putting the DNA for this product into the ovarian cell cultures, and then they produce it and purify it, and that's how they make it.
Would it be an existing manufacturing facility that's designed this way, or would you need to build one custom for this?
Because this is a technique used for other drugs, I'm sure that an existing manufacturing facility that would have capacity could easily do this.
Yep.
So it's not a brand new technology, it's just a brand new substance being produced by existing, well-understood technology.
Gotcha.
And when I talked to the head of clinical direction at SIM, and I asked her how expandable is production, because in Cuba they're looking at having to make many thousand doses. I looked at the United States, it's like, year one we're going to need 600 million doses. This better be expandable. And she says easily expandable. The problem is in Cuba, because the embargo prohibits them from getting some of the high-tech evaluating equipment that we have here. In order to make sure that this does not stimulate production of red blood cells, they tested each batch in mice and make sure the mice don't make excessive red blood cells. So she was telling me that the only limiting factor is finding enough mice to test the batches with. Well, in this country, we're not going to be testing it on mice. We're going to be running through some sort of a analyzing tool that says, yeah, this is not something that's going to make red blood cells. And so it's very expandable. It's a technology that's well understood. And so we just need to find a facility with marginal capacity that can produce this. I'm not thinking we're going to start building factories to get started.
Well, because you'd have to get approval here in the U.S., right? So you're getting approval from Cuba.
And Cuba has basically agreed to license the technology, allow us to produce it and distribute it outside of Cuba. And they realized that they couldn't possibly meet the needs of the world from what they can manufacture in Cuba. And even if they put in plants elsewhere, this is going to be the transformative drug of the decade, if not of the century. If we can take 9.6 million people with dementia and make a majority of them, a vast majority, stable or better.
I mean, that'd be gigantic.
Unbelievably gigantic.
Especially for, people like at our ages, when we're starting to look at that and wonder if something's going to come along in time.
When did my parents start to lose it? How much genetic propensity do I have for getting this? Maybe I should. How safe is this? Well, the answer is, with over 1,000 people taking this medicine, and with them following every patient closely, the only side effects they've seen is that after the patients get the drops in their nose, they complain their nose is wet. About 3% of patients say, my nose feels wet. A couple percent say my nose itches or my nose burns. No one has stopped the drug because of a side effect. The only side effect is when you're lying back to get the drops in your nose, and when you sit up, sometimes you feel dizzy. Well, if you don't get the drops and you do that and sit up, you're going to feel dizzy sometimes.
Yes.
So it's an incredibly safe drug. There's no drug-drug interactions, and no one has yet had an allergic reaction to this medicine. Administered by nose drops 3 times a week. Now, nose drops 3 times a week, it's like, where did they come up with that? Well, they studied it. And the nasal brain pathway is well understood, and there's a couple of drugs in the United States that are using that currently to try to treat MS and try to treat Parkinson's disease. And in Cuba, they did studies where they measured the level of this drug in the brain after giving it intravenously and after giving it by nose drops. And they got about 10 times the concentration in the brain after nose drops compared to intravenous. So it's a remarkable drug, a remarkable technology, remarkable results. And every week that we don't get it here, another 16,000 people tip over into non-functional.
So how do you go about getting this, building the awareness,
That's right.
getting the approvals, getting them to take you seriously when you're bringing it forward?
Well, the first step is what we already have done and are refining is to put together the dream team. Find people who have expertise in clinical research, expertise in getting things through the FDA, expertise in the politics of getting things done, and credibility. And we're putting that together.
Do you have any of those people lined up yet?
We have many of them lined up. There are many positions left to be filled. And the people we have lined up, the people who know how to get things to the FDA, know how to put together clinical research, know how to interpret clinical research, they're ready to go. They're the bread and butter of getting this thing going. We still need, once we get rolling with this, we're going to need to hire more people to do more things. But right now, we have a good, solid core of expertise and credibility. I mean, we have one Nobel Prize laureate who's on our team who's very excited about this. We have a guy who used to be a VP at AbbVie Pharmaceuticals who's very excited about this. And so that's the first thing, put together that team. The second thing is if we can get a study through the FDA and start showing results, and this is so effective, we're probably going to show results in 6 months. This is not going to take a 10-year study. We'll probably start showing clinically significant results in 6 months. And then make people aware this is what's happening. And I think everybody knows somebody who has dementia.
Sure.
Who could benefit.
And will they pay attention to the studies that are being done in Cuba? I'm sure going to want to see it done here as well, but I would think that some positive signs here combined with them seeing the outcome of the studies in Cuba would make them have a sense of urgency to want to see get approved there.
Yes, absolutely. What we're currently doing with Cuba is they have agreed us to send us all of the primary data that's gone into every study they've ever done on this drug. And we're going to process that and put it together in a portfolio to bring to the FDA and say, this is what Cuba has done, this is what they found, and these are our conclusions based on that. And if the FDA chooses to believe what came out of Cuba, we can get accelerated very, very rapidly on this. The problem is it's Cuba, and we are egocentric. And I was egocentric 10 years ago.
Yeah.
I didn't think for a second that going to Cuba for lung cancer made any sense. I went along. And now it's like, when I look at what Cuba has for treating hard cancers, and I look at what we have in the United States for treating hard cancers, and I see the future of combining those technologies, we might change the face of hard cancers very quickly just by combining what they have with what we have. But we have to talk to each other first, and we're not doing that hardly at all. So get that through the FDA. The new head of the FDA is a breath of fresh air. I mean, he's looking at how do you accelerate the approval of drugs that fill critical needs. And if any drug filled a critical need, this one fills a critical need. Say what you want to say about RFK Jr., he's not a dumb man. And I think that he looks at Cuba through different lenses than a lot of people. He's not unfriendly to Cuba. And he has respect for Cuba's medical industry. And so Kennedy's not going to be a problem here. I think that
Well, one thing you got to say about Kennedy, I mean, we are talking more in this country now about how poor our health is, how poor our wellness is.
Absolutely.
And we're exploring things that weren't being explored, a year ago. I know it gets caught in a big political firestorm
Yeah.
about anti-vax, and he's not a scientist, he's not a doctor, but he's bringing to the forefront conversations absolutely need to be had, and in asking the question, why is it that we spend more than any other country, and why is it that we're more sick
Yeah.
in the country? We're less well, we're less healthy. Something doesn't add up, and if you don't have someone there who's willing to kind of question fundamentally what we're doing, it's not going to get any better. So it's frustrating to me when I hear politicians in particular be so anti-RFK without acknowledging how horrible of the outcome that we've produced for ourselves has been.
That's right.
It's crazy.
And the problem with RFK Jr. in our current entertainment industry masquerading as news,
Yes.
he is such a soft target. He's easy to poke fun at and try to make to look as a fool. But like I say, he's not a stupid man.
He's extraordinarily smart guy. I mean, I've heard him on multiple long form podcasts where you can't hide. I mean, you're on there for 2.5 hours with Joe Rogan, and you're going deep. If you're an idiot, that's going to come out.
It's going to come out quick.
Clear.
Yes.
If you're extremely intelligent, that's all that's going to come through. And there is no question he's very very knowledgeable about the topic. He's very intelligent. I mean, for him, the way he's able to recite and remember kind of facts. Now, has he maybe pushed things a little bit too far at times to catch? Maybe he was trying to catch attention. Maybe he couldn't help himself. But it doesn't really matter to me. It matters to me that we're having conversations that need to be had, and we're revisiting the institution of who's guiding us when it comes to health and wellness, and that's desperately needed. And we should be very appreciative that he's willing to do that.
And no, I try to steer clear of politics as much as possible. Because the value of this medication far exceeds any value that any politician is going to ever bring to us in our lifetimes. That said, I think that if Kennedy gets wind of this, that's not going to be a bad thing. That's going to be a good thing.
That'd be a great thing.
And if that and the new head of the FDA, I just have a sense that he's going to look at this with different lenses than people who are so built into the biopharmaceutical industry of the United States. I've talked to some of these folks, and they say, it's Cuba, forget it, they don't do anything. I know these people. I know what their motivations are. I know what their scientific precision is. They're good researchers, and this is real data. And so here's the other thing that I'm not reluctant to share, but I realize that there's some risk in me sharing this. Cuba does international medicine. So if you or your friend has early dementia, you can go down to Cuba to La Pradera International Clinic, be evaluated, and if the neurologist in Cuba says, yes, you qualify for this medicine, the neurologist can prescribe it for you, and you can bring back 48 weeks worth of this medicine and can use it. As it turns out, I have 24 patients who have done that. And of those 24 patients, a couple of them are approaching the 6-month mark of being on this medicine. Many of them are approaching the 4-month mark of being on this medicine. The results that I am seeing here among my patients who are going down to Cuba for this drug are truly remarkable. I am seeing better outcomes than what Cuba found in that first study. And I'm seeing benefits in the realm of Parkinson's, in the realm of traumatic brain injury, in the realm of post-stroke, as well as in the realm of dementia.
So what are you observing with these?
So these are people.
24 people.
These are people. When I find out that this is their plan to get this drug from Cuba, we do a baseline MOCA, which is a Montreal Cognitive Assessment, which is standard dementia assessment that's frequently used in research. And we do an auditory evoked response.
And how does that work? How does that?
That's just a test that you take the test, I ask you the questions, you answer the questions, and I give you the piece of paper and say, draw a clock, and you draw a clock, or you say, name these animals, and you get a score up to 30. 26 is normal. So if you get above 26, you don't have dementia. If you get below 26, you're not normal. And so you can see we have a numerical assessment of their level of dementia. But then we do an auditory evoked response EEG. And so what this is, you put an EEG on the patient, and put on headphones, and a certain high-pitched click comes through periodically. And every time the high-pitched click comes through, you tap the space bar with your eyes closed. And this gives you a pattern of brain waves that measures frequency, measures amplitude, measures a number of relative factors. It gives you a metric of how your brain is working. And so we may not be able to diagnose dementia off the MoCA, but it gives us a numerical valuation of how fast your brain is responding, what the frequency is, what the voltage is, a number of relative relationships between the occipital, parietal, and frontal areas that are patterned differently with dementia than with normal brains.
And this is, if you went back a year ago, 3 years ago, 5 years ago, would you be using these same approach when one of your patients comes in and you think they might have
3 years
dementia?
ago, because we had nothing to treat dementia, I was in no mood to find dementia at its earliest stage. Because if I'm looking for dementia at its earliest stage with nothing to do about it, I can say, guess what? Now you have dementia, and you're also depressed because I just told you have dementia. So I had no interest in that. Now that Cuba has a drug that can stop dementia in 84% of the patients, I want to find dementia before you even know you have dementia. And if you drop off on the cognitive scale and we can predict that this is going to keep going down, I want you to be aware that this drug exists, and if you can find your way to Cuba, you might be able to do something about your dementia. And I want to, that's all the more reason to get this drug available in this country. Make it easy. And when you look at the cost savings to the healthcare system, of that $300 billion we're going to save every year, $190 billion of that the federal government will save. $110 billion individuals will save, state governments will save, private insurers will save. $300 billion is a lot of money.
Yeah,
It's a lot of money.
you could probably pay for that new hall that Trump is
New
putting in the
wing,
White
yes.
House, right?
That's right. With
So-
some change left over, yeah.
Yeah, with some change left over. Okay, so
In
this
fact, you buy
test
1,000 of them every year.
and the tests that you're doing, that's pretty standard tests for people with.
They're standard tests. Yeah, the auditory evoked response, EEG, has been in research since 1980 and has been felt to be a good predictor of future dementia. But I'm not using it for that. I'm using it just as a numerical metric of how are you today, how are you going to be later. And so I've only had one patient who's been on the drug long enough to get 2 of these tests. And it's an interesting patient, a young fellow who got blown up twice in Afghanistan, a traumatic brain injury, and was having late manifestations. His balance wasn't there. He was running out of energy by noon. He just couldn't function in the afternoon. He had to lie down. It was done. And his ability to maintain a thought process was diminishing, just getting worse. And he was able to get on this drug. And we did a auditory evoked response EEG at the beginning, and we did another one last week. Virtually every metric on his auditory evoked response was improved. Every metric. But more importantly, 3 months ago, he was at my house. He's a relative of sorts. He's a relative of sorts. He's a good guy. He's at my house 3 months ago and tried to flush the toilet and fell into the bathtub. His balance was that bad. Since then, he hasn't had any more falls. He was able to jog around my kitchen island because he was feeling so much better. His psychologist has observed that his ability to stay on task is substantially improved. And he was no longer having the balance issues he was having. So not only did he clinically look substantially better, his EEG showed significant improvement in metrics. In fact, with this, one of the metrics you get is how long does it take for you to hit the button after you hit the beep. Well, the first time, he was 30% above the upper limits of normal. This time, he was near the middle of normal. So just ability to respond to a stimulus was back to normal. But more importantly, maybe equally importantly, the voltage, the frequency had all moved towards normal. It's like, so not only do I see you better, you can't fake the EEG. The EEG is the EEG. And all these metrics being better, so it's like very, very exciting. And his dementia was not a big part of it. He got 20 out of 30 on his MoCA. He did not have dementia, but he had the other manifestations of closed head injury that have been improved by this drug. As it turns out, Cuba was planning on using this drug for closed head injury before they found out that it also worked for dementia and realized dementia was a much bigger need. So they did a study with dementia. And once again, because Cuba is an impoverished nation, they have to pick their studies carefully. They're currently doing a study of traumatic brain injury. And I'm friends with the person who is in charge of that study, the principal investigator. And I was in Cuba a few months ago and I asked her, what can you tell me about the results of your study? And she looked at me like I was an idiot and said, it's a phase 3 trial in progress. I've got nothing for you. It's, talk to me in a year. But don't be stupid. It's a phase 3 trial. I don't know what's going on. It's blinded. People are getting better, might be getting placebo for all I know. And so once again, that validates they do real science.
Yep.
They do real science.
So you say you observed multiple signs of it's early, but multiple signs of the 24 people getting better. How have you observed with others if they haven't gotten to the second test yet?
So one patient had a stroke 20 years ago and another stroke 2 years ago. She has problems with balance, problems with vertigo, and she was starting to have problems with dementia. So I made her aware of this product. She gets it. She's been on it for about 2 months now. Her physical therapist observed to her, your balance and gait are significantly better since you've been on that drug. Without, that was the observation of the physical therapist to her. She and her husband both agree that globally she is better. I have a sister-in-law who has dementia. To my surprise, I didn't know she had it. 3 months ago, I was visiting her, and it was clear she was asking the same question again, and in a couple minutes, ask the same question again. She would be outside with my wife and turn around, walk in the front door, and ask where my wife was. So we were really, really concerned about her. She's been on the drug for 3 months. I spent the weekend with her in Santa Barbara. She did not once over the weekend say or do anything that would raise a concern about her cognition. So in 3 months, she's no longer showing any outward signs of dementia. Have the first patient who started on this, historically, she could not tell me what she had for breakfast. She could not name her grandchildren. She could not tell me the day of the week or the year. I saw her last week. She's been on the drug for 6 months now. She told me all of those things. She named all of her grandchildren. She knew what day of the week it was. She knew what year it was. And she knew what she had for breakfast. She couldn't have done that a year ago. And so another patient was not any better. And we tested him, and indeed, he was not any better. And then I realized he's getting 4 milligrams of Valium and 15 milligrams of Zolpidem for sleep at night. If I was taking 4 milligrams of Valium and 15 of Zolpidem, I wouldn't be able to speak today. So let's get you off of some of this, see if your cognition doesn't get better. But he has Parkinson's. And with Parkinson's, labile blood pressure is oftentimes a huge problem. Since he's been on this drug, his blood pressure is stabilized. It's no longer labile. The labile blood pressure has been a problem for years. And with Parkinson's, once you get this autonomic dysfunction, it don't get better. His stabilized and is no longer an issue. Huge. And so even though he didn't see improvement in his cognition, we saw an improvement in an element of his Parkinson's disease. So when I see the stuff in Cuba that I believe, because I know the people who developed it, and see the limited stuff that I'm seeing in the United States, any shadow of a doubt that I might have had is long gone at this point in time. This is the real thing.
So what's the path forward?
Well, the path forward is hopefully between now and when the FDA approves this drug, people in this country with early, mild to moderate dementia can find their way down to Cuba, get the drug, and start taking it. Stop it in its tracks. Maybe make it better, but stop it in its tracks.
Let's say someone's listening to this and their parent or loved one, they want to explore what.
La Pradera, Lapradera, International Clinic.
Well, let's say it again.
La Pradera, the Prairie, International Clinic in Havana.
So spell that again.
Lapradera.
Okay.
La Pradera. You can Google it. They have a website. You can send them an email, and they will tell you what they need in order to have you come down. And when the first time I came down with a patient to La Pradera, I was petrified. It was kind of a scary proposition. I get there. There's a nurse from La Pradera waiting for us as we get off the plane. They get us through, passport control. It was just so easy. They had a bus waiting for us. We go down there, and the whole thing was just smooth as silk. It was very easy. You know, it is Cuba. It's not a third world country, but it's not the United States.
Mm-hmm.
You have to drink water in bottles. Yeah, there's
Kind of like
certain
New
things.
Jersey is what you're saying.
Kind of like New Jersey. Yeah, but it's not horrible. It's not a third world country, and the taxis are fine. You can get a 1956 Chevy and ride in that if you want. You can get a
Yes.
modern taxi. Both are available. I kind of like the 56 Chevys, but both are available, and so it's not an unpleasant trip. And with this dementia drug, it's worth the price of admission.
Yeah.
It just is.
Imagine.
And then hopefully soon we can get an accelerated approval through the FDA and get available in the United States, because with a drug this safe, this effective for a disease this bad, there's no argument against it. There's no legitimate argument. This is the transformative drug of the decade, if not of the century. This is going to change so many people's lives in a positive way.
And what else do you think Cuba,
Well,
can do? And
basically, when you look at the other biopharmaceuticals in Cuba, they're cancer drugs. They have 3 cancer drugs, immune-based cancer drugs. They've been using for over 10 years. They have 14 drugs they're still studying and working on that they haven't put into clinical use yet. But with cancer, I like to use AIDS as an example. When AIDS, I was in medicine when AIDS was invented, and I was in medicine when AIDS was cured. That was quite a thing to watch, for this becoming a universally fatal disease to eventually a disease that didn't change your life expectancy. It's not cured, but a disease that's not changed your life expectancy. That was an emotional roller coaster. Well, with AIDS, AZT was the first drug for AIDS, and it worked, and it gave you about 2.5 years of life before the virus became resistant and you got sick and died. Then they came up with a second drug that gave you another year, and then a third drug that gave you another 7 months. And if you use them in series, you got 3.5, maybe 4 years more with AIDS. And took those same 3 drugs and used them together, and AIDS stopped killing people. Well, with cancer, when you look at chemotherapy, you can't stack chemotherapy because the chemotherapy will kill everybody. But here's the math. How many mitoses, how many cells have to divide in order to get a mutation against one drug? And so make up a number, 1 million. That's not a big number in the world of cells divided. But 1 million mitoses to get a mutation to the drug. Well, how many mitoses does it take to mutate to 2 drugs at the same time? It's actually 1 million times 1 million. How many does it take to mutate against 3 drugs at the same time? 1 million times 1 million times 1 million. Turns out that's a really big number.
yeah,
And you're probably not going to make it in most cases. And so we can find 3 effective treatments for lung cancer, for prostate cancer, for pancreatic cancer, glioblastoma, these horrible, well, prostate's not horrible, but the others are dreadful cancers that we have nothing much to offer for. Metastatic colon cancer. What if we have 4 very well tolerated drugs that hit different spots in the cancer and work? Those may exist today. Just 2 of them are in Cuba and 2 of them are in the United States, and we haven't talked enough.
Yeah.
They may exist today. We may see cancer go through the same pathway that AIDS did a couple of decades ago, or for that matter, that tuberculosis did. I mean, tuberculosis has 3 drugs we use to treat tuberculosis. If we use them in series, the tuberculosis becomes resistant. We use them together, the tuberculosis dies. We need to do the same thing with hard cancers, and immune therapy, laser-focused immune therapy, is what's going to do it.
So let's talk funding.
Yeah.
How much funding do you think you would need to really get this?
Yeah.
So
as it turns out, getting a phase 3 FDA study to get a drug approved is an expensive process. And so when you look at the average cost of something like that, it's in the realm of $50 million to get a phase 3 FDA-approved study to get a drug approved. Once you get it approved, you still have the manufacturing to achieve, the marketing, the distribution. You put it all together, it's in the realm of $200 million to get the whole thing done, which sounds like a lot of money until you look at the $300 billion that will be saved every year in healthcare costs.
Yep.
$200 million is a drop in the bucket of $300 It's not, it's more than 1,000 times 200 million to get to 300 billion. And so I think that it's 1,500 times, in fact, to be exact. And so that, at this point in time, I'm kind of funding what we're doing right now. I'm not going to be able to come up with $200 million. I'm going to need some help, people.
Yeah, well, you never know from these.
That's right.
And if someone who's very much a specialist in this, hopefully this finds their way to them.
Yeah.
Certainly reach out to me. I would, talking to the camera right now, reach out to me if you've got interest and expertise, and let's talk. Maybe we could do something together.
This, like I said, at the end of the day, from my perspective, the reward is helping the patients. When you look at it from a financial perspective, if I were in it for the money, there's huge money to be made here. Mm-hmm. I don't mind making money, but I'm not here. I have all the money I need. I don't need a lot of money. Mm-hmm. I need my patients with dementia to stop getting worse. That's what I need. For the last 39 years, just watching people get worse and worse and worse and go to a nursing home and die a miserable death. And we have something that can stop that. I can't describe how compelling that is. Very compelling.
All right. Well, that's probably a good place to end this.
All right.
I appreciate you coming on here.
I appreciate you having me.
Yeah, hopefully this helps you in the journey of figuring out a way how to get the approvals, how to get the funding, and how to save a whole bunch of lives.
A whole bunch of lives, a whole bunch of money, a whole bunch of misery for families.
Yes, absolutely. All right.
Thank you much. Really appreciate it. Thanks, Dan.
Thank you for listening to this episode of The Bear Roars. Check out Stretch, the new song from Dan Caruso, with music by Jason Mendelson, available now on all streaming services. If you enjoyed the episode, please like and subscribe on your listening platform. This podcast was produced by Loud Bear Productions and edited by Kendall Weinberg with support from Gibson Siegert.